Thank you everyone for joining us today. I think we've got a really exciting lineup of very knowledgeable speakers. So we're going to kick off with a couple of welcoming remarks. Then we will go into a brief presentation on the NHS, a recap for those of you who know the system, and an introduction for those of you who don't. We'll hear from Tara Donnelly, who will talk about supporting people at home and touch on some of the transformation that's happened, especially now during the pandemic. We'll hear from Tony Young about embedding innovation in the NHS, and then from Juliet Bauer about how to succeed, specifically from almost a Swedish perspective. And then we'll round off with my colleague Johan, who'll give some summary and touch briefly on possible next steps in order to capture the variety of business opportunities that are out there. So with that said, I would like to hand off the word to the ambassador of Sweden to the UK, Torbjörn Solström, who's joined us for some remarks. Torbjörn, would you like to take it away?
Well, thank you very much, Edward. I just want to say good morning to everyone. A big welcome to our participants from who are joining in from Sweden. Welcome to the UK. Welcome to London, even if it's only virtually, but you see some nice London skylines on the pictures. So many of us are already in the UK, and you're welcome here to join us. And then a big thanks to the organizers of this and to our British participants. It's really amazing that in these busy times that you have made time available to speak with us and with Swedish companies. It's usually appreciated, and I hope that people joining in from Sweden understand what the royal treatment they get by having access to such key people in the on the UK side and within the NHS. I'm not going to take, this is not my show, I'm not going to take valuable time. Suffice to say that I personally believe that Sweden and the UK are very natural partners when it comes to innovation and healthcare. We have seen it in a somewhat from a different angle and on a different scale in this pandemic through the work of AstraZeneca, obviously a British-Swedish company. I don't think they can take all the credit. A lot of the credit for vaccine work goes to Oxford University and the people there. But it is somehow symbolic that it is if there is one Swedish-British sort of symbolic company and merger, it is the one between Astra and Zeneca, and that they are I think it's symbolic that they are at the forefront of fighting the pandemic. But before all of this happened, during the pandemic, and also on the other side of it, when we eventually get out of the shadow of COVID, we know that when it comes to bringing innovation, adaptation into the healthcare area, we think very much alike, and we have very much to learn from each other. And there are great business opportunities for companies that can find ways to make care more efficient, more effective, and more available for people. Others have done it before you, and I very much from my side welcome that strong links are created between our countries in this area. And on a political level, we want to take that forward as well. I'll stop there and hope you will have an enjoyable day.
Thank you very much, Torbjörn. I'd like to hand over the word to Noel Gordon, who was gracious enough to join us as well. Noel.
Well, good morning, everybody. Thank you to the ambassador. Thanks very much also to Gustav and the whole Business Sweden team who've organized this. And indeed, thank you to the really excellent speakers that have agreed to join the seminar this morning. And of course, welcome to all participants joining from Sweden. It's a great opportunity for us to speak directly to the Swedish medtech, health tech, and broader healthcare sectors about the NHS, about some of the things we are doing, some of the things we are trying to do, and also, you know, we are now very shortly going to be global Britain. So reaching out to countries like Sweden, who, as the ambassador said, we have great cultural affinity with, and we share almost a common language, which helps. It's a really excellent timing. It's really excellent timing, of course, because in the last 6 months, the environment for innovation in the NHS, in UK healthcare generally, has very much changed. And I have to say, changed for the better. And if I were to offer 3 reflections to share with you on what just happened, I would probably highlight 3 particularly momentous changes for us in the UK. The first reflection I have is I think the NHS itself has opened the door to digital transformation. And that may seem a strange thing to say, given we've been on a journey for the last 6 years, 7 years probably, to digitize the NHS. The speed with which we have had to move in the last 6 months has been quite extraordinary. Telemedicine has now become a perfectly normal channel for delivering NHS services, and you have Juliet from Livy Creek coming on later this morning, and they are one of our most important partners in the whole telemedicine experiment. Sharing data, that has moved so fast in the last 6 months. We've broken down barriers thanks to legislation, which allow us to get much closer to where we want to be in moving patient data. We have really important but somewhat micro examples like digital paramedics, digital ambulances, which now can receive images of patients on site at trauma in advance of actually meeting the patient. And we've been able to, I think, move toward the second reflection I have, which is get us closer to this ideal that we've sort of talked about a great deal over the last few years, which is the concept of connected health. Delivering health in the home, delivering health in the community, delivering health, as I said, through ambulances, moving more to digitizing whole care ways. Now, we've still got a long way to go, but this concept of connected health and bringing in new technologies which are relevant to the health IoT, such as sensors and data which we can, devices we can give patients to help us understand their condition when they're not in a hospital setting, have all been major breakthroughs for us in getting to understand the concept of how we deliver connected health. I think my third reflection is we've learned how to make decisions faster. We stood up 6 field hospitals within about 2 weeks. We're mobilizing for mass vaccination, hopefully beginning in December, on a scale which ultimately will be national whole population mobilization of whatever vaccines become available. We've had to mobilize the test and trace, and that's had its teething problems, but we've mobilized test and trace on a national scale. Smaller examples, we've shipped updates to triage algorithms every 24, 48 hours. We have national data sets or business intelligence dashboard, which allow our government, our Prime Minister and our Cabinet Office to see a total picture of the way the virus has been moving, our capacity to support hospitals, where we have hotspots, and we could not have imagined a national dashboard for both demand and supply 6 months ago. We stood that up with the help of Palantir. But my general point is we've learned how to make decisions faster. And, you know, there's nothing like a global crisis to teach us all how to grow up faster. And we've had to learn as we went, not just the bureaucrats at the center, but decisions faster made by clinicians, nurses, hospital administrators, everyone, in a sense, has had much more freedom to apply their intelligence and their intuition very often in how to deal with some of the exigencies of this crisis. Hopefully, the adoption and diffusion of digital technologies in the NHS has also accelerated. I think it has. Our speakers today will no doubt comment on that. But we're getting closer to being agile, and I mean that in the very broadest national sense. So I feel those three important pivots, at least from my perspective, are here to stay. I don't think there is any way we are going back. I think the concept of speed, of finding solutions that the marketplace has stepped up to provide us with, and it's up to us to make the most use of them. I think the way we've decentralized authority in a sort of tight, loose sense is here to stay. I hope it is. So our guest speakers today, I'm sure, will expand on some of these themes from their own perspectives. And I very much hope that our participants from Sweden would benefit from today's seminar in at least three ways. Firstly, I hope you get a deeper understanding of how the NHS works. It's a complicated beast for all of us, in fact, but having some insight into the solutions we need, I hope will be your first takeaway. Secondly, I hope you will learn a bit about how to navigate the sales process, which is complex, but hopefully for all the reasons I've just shared with you, it will be easier than it was. And thirdly, I hope you take away a sense of where we're looking for ideas that will help us in the journey we've just accelerated in. And there are no better speakers than the three that you have today, all of whom I know, and I can see Tony Young on the screen right now, who is a force of nature and a great dynamo within the NHS in reminding us of the importance of digital and technology and data in everything we do. So I wish you well. I'm going to hand over to Gustav now, but thank you ever so much for joining us, and I hope it's a great opportunity for both sides.
Right, thank you very much, Noel. Thank you for joining today's call, and also I think for your continued support in building this healthcare relationship between the UK and Sweden. It's much appreciated. As you discussed, Noel, it's been a fantastic year in terms of the digital transformation within the NHS and in its response to the pandemic. We see that the NHS is taking very important steps to transform how it provides care in order to address the numerous challenges which it faced both short-term this year, but also in the future. With this comes a lot of opportunities that you've discussed, Noel, and we often see that Swedish companies have quite strong and competitive offerings towards the NHS. However, we also see that companies relatively often underestimate the complexities of the system. It is a fairly complex system to get the grip of. So we think that in order to being able to succeed and provide value to the NHS, companies really need to have an in-depth understanding of issues such as, obviously, the system itself, the stakeholders of relevance to your company, who is really the customer, how your solutions provide evidence-based clinical value, and also how they provide cost effectiveness to the system. With that said, we have a great panel today, and they will very kindly share their expertise and insights with us, and I believe answer some questions if you have that. So really take the opportunity to engage with these really key players in the UK healthcare system. That's it from me. Over to you, Edward.
Thank you, Gustav, and thank you, Torbjörn and Noah, both of you for your remarks and for helping us open this session. We'll now move into just a brief overview of the system. Again, a recap for some of you who are familiar with it, and an introduction for some of you who aren't. Talking about touching on some of the complexity, and also touching on some of the opportunities that I'm sure our speakers will dive a bit deeper into as we move forward through the webinar, and that we'll touch upon in the conclusion. We do have a video as well from DIT. Unfortunately, Linda from DIT couldn't join us today, but she has recorded a video from a previous session and shared that with us. So that will also help give us a good overview. Fingers crossed that the technology cooperates with us today. So we are talking about a very large system here, one of the largest healthcare systems in the world. In 2018, total UK current healthcare expenditure was £214 billion, and that is expected to continue growing over the next 4 to 5 years. The majority of that, 78%, was government financed. And when we say government financed, we mean primarily NHS. So there is a lot of money and a lot of government backing being put into healthcare here in the UK. And that obviously then entails a special system and a special approach to the system as well. We have approximately 7,000 GP practices in England. When we speak about the countries of the UK, which I know that one of our speakers will go into, we very much talk about the devolved nations, England, Wales, Scotland, and Northern Ireland, and they have their own NHS systems. So for today, very often we'll speak about the NHS in England. So approximately 7,000 GP practices in England in 2019, which was a decrease of 18% since the mid-2000s, but an increase in the number of patients that each GP clinic services with approximately 45%. We've got about 300 million GP appointments a year. So again, speaking to that volume, that largeness, and approximately 223 trusts in the UK. And for those that don't know, a trust is essentially a managing body of one or multiple hospitals. It may be that a trust manages a single hospital location or manages multiple within a defined geographic region. So we've got about 223 of those bodies that are helping to manage the operations of the hospitals in secondary acute care. We also have mental health trusts as an example. We will move into a video presentation from DIT. Let me see if I can get this to work. Are you able to hear the sound on that? Otherwise, maybe I need to present a different way. Let me try this. Apologies. Apologies for the technical difficulties. Can someone let me know when you can see my screen there?
Yep, can see it.
Okay, let's see if this works. Please let me know if you can hear the sound. No sound yet?
It's very low, I would say.
Okay, let me try this. Is that working better?
I still can't hear anything, no.
My sincere apologies for this. Yeah, I think that'll be best if I talk through the presentation. Apologies. This will be sent out at a later time, so you will have access to the video. Let me just load up the presentation again. Ah.
You can hear something, but it's very low, Edward. I think that both Ade and Jack have the video up.
Yeah, Jack, could you share? I will hand over the word to you. Again, my apologies that this is not cooperating with me.
Yeah, absolutely no problem, Edward. I'll share now. Hopefully it works for me.
And I'm the Health Innovation and
Is that working? Can people hear that?
Yes, thank you.
NHS specialist for the Department for International Trade in the UK. I'd like to thank the organisers for inviting me to take part in this event, and I'm sorry I can't be doing it in person on the day, and this is a pre-recording. However, I've got a lot to cover in 15 minutes, so I have put some additional information on the slides for your reference. So, to start off with the UK opportunity, the UK is a prime location for not only identifying innovation, but also to research, develop and evaluate your products and services within the National Health Service, widely regarded as one of the world's best healthcare systems and can be a test bed for your global market development. We have a lot of dedicated infrastructure to support that innovation pathway, more of that later. We have national agencies coming together ever more closely to improve the pipeline and adoption process for streamlined market entry. We've got a very significant commercial sector across clusters in the UK, and they offer all sorts of opportunities for companies of every type. And we have a very strong government commitment to innovation, which is underpinned by sustained partnership with industry through our life science strategy and sector deals. So straight on now to the National Health Service. It is an organisation with under a single umbrella. However, there are 4 NHSs within the UK, within our devolved countries. And I'm going to focus in for this presentation on NHS England, which, as you can see, is the majority of the population at 83%. But I know other speakers will cover some of the other devolved opportunities. And for some companies, they can represent very particular opportunities if you're starting to enter the UK market. It's also worth highlighting that the NHS represents 85% of the UK's healthcare market. The other 15% private healthcare is mainly funded through health insurance, and of course some of the private companies do provide services under contract to the NHS. So who does what in NHS England? Well, we have the Department of Health and Social Care, government department, which funds the healthcare system via taxes agreed by Parliament. The majority of those funds flow to NHS England, but also they cover their core department costs and various agencies, units and arm's length bodies. Among those would be the National Institute of Health Research, the Medicines and Healthcare Products Regulatory Agency, and the National Institute of Health and Care Excellence, and I'll mention them a little bit later. So The NHS funds commissioning specialised services and general practitioners, for example, and the healthcare system is regulated by our Care Quality Commission, the CQC, and also NHS Improvement. And NHS Improvement and NHS England essentially work together under common management system. And the healthcare products are regulated by the MHRA. NHS commissioning is the process of planning, agreeing and monitoring health services and to ensure they're provided effectively for the needs of a given population. And commissioning occurs at both national level through direct commissioning and local level through the clinical commissioning groups. And again, I think there are other talks in this event on the CCGs. The providers deliver the commission services. There's NHS trusts, primary care and GPs, and they're paid in various ways. And again, this is where we do get slight differences between England and the other devolved nations. And it's also worth highlighting that our general practitioners are the gateway to the NHS for the patient. There are exceptions, for example, self-referral to accident emergency and some walk-in centres. Now, as with all modern healthcare systems, we face similar challenges and market drivers. We have an ageing population. My colleague Julie will be speaking about that at this event. We have increases in comorbidities and the development in ever younger people, particularly in things like diabetes, for example. There's a growing desire for individuals to have more choice and empowerment, and also greater expectations of the healthcare that they will receive. And finally, and inevitably, rising costs. So what's the NHS doing to respond to these challenges? What are its priorities? Our NHS long-term plan was published in January of last year, and it's a long document and is available to read online, but here are some of the highlights. So maintaining and ideally improving the quality of care and reducing inequalities, improving efficiency, and that is doing more for the same or less, but ideally efficiency where you can get cash release. Keeping people out of hospital. Only people that really need to be in hospital should be there, and there they should get the best possible care. But a shift to delivering more and more services at a local level or in the home. It's recognised mental health is equally as important as physical health, and the two are interrelated. And for the first time in its history, the budget for mental health has increased in the new plan. Prevention, early diagnosis and improved management of long-term conditions have received a great deal more attention, and in the technology end, funds for new genomics and that includes end of life.
Thank you, Jack. I will share my screen once again. Please let me know when you can see that.
Yep.
Fantastic. So as was mentioned in the video, we see three major focus areas. I won't spend a lot of time on this because I'd really like to get to our speakers, but I think the key here is we do really see a commitment to a future driven by digitalization. There's both strong investment and prominence in the long-term plan. There are timelines that are committed to in terms of fully digitizing the system, but we do still see potential challenges in terms of a digital-first approach, transforming this into a person-centered service model that's really aided by digitalization, and then lowering costs while still delivering the same or higher quality of care. As we have seen, pandemic has been a catalyst for some of these leaps, and we will that provides a nice segue into our next presenter. So I would like to welcome, see if I can switch slides there. Oops. Tara Donnelly, who has been gracious enough to join us. Tara is Chief Digital Officer at NHSX, and I know that she's going to speak about supporting people in the home. Tara, are you with us?
I am indeed. Thanks very much,
Fantastic.
Edward.
Not a problem.
And I'm going to rattle through the slides, so maybe if I wave, that can get that can on. But just before I do, so we're a joint unit set up just over a year ago between the Department of Health and Social Care and NHS England, with an explicit ambition to accelerate digital across the NHS and social care. And we do this in 3 ways: digitise, connect and transform. So digitise is about bringing the kind of modern day internet-based service into healthcare. Connect is joining up records and data so that people have the information they need. And transform is the bit I'm going to talk to you a bit more about, which is that as well as digital providing new routes to access healthcare, like video consultations, we're keen to really change clinical pathways and support them with evidence. That's some of the work that I'm involved in. My background is I've worked in the NHS in operational roles for all my career. I've been a chief exec of hospitals and operations director. So I come from this not with the expertise of a technologist, but more as somebody who is looking for evidence solutions to real world problems that help patients and staff. For 3 years, I also ran a digital health accelerator in London, part of the AHSN offer to innovators, and therefore the ambitions of digital health innovators are quite close to my heart. So my job within NHSX is running a small team that provides some innovative support, but mainly focuses on scale of evidence solutions in particular areas. I'm going to talk particularly about the remote monitoring work here. Because we feel that's the way that we can provide most value as a small national body to the NHS more broadly. Great. So, and I thought I would just talk about coronavirus and some of the digital work that we've got involved in, because I thought that might be of interest to you. So during the first wave, we paused our normal work programmes, and a team of us approached, in fact, initially by a clinician who was running quite a large virtual ward from his hospital. I don't know if virtual ward is an expression that translates well, but essentially looking after people who are acutely unwell, but allowing them to go home with supervision, which often is telephone calls. And this doctor approached us to say, have we got any technology that could help him manage his patients differently? He approached us in early March, and 4 weeks later, we were live with a tech-supported service using one of the many pro bono offers that we got during the COVID response. So we were able to sort of twin this need with a product that was out there to enable people to leave hospital much earlier, track their symptoms through a smartphone app and a pulse oximeter, and provide clinical oversight that way. And that's now in 10 different hospitals and primary care hot hubs across London and the home counties, and we're currently working with 50 other services to spread the model during second wave. Next slide, please. So a little bit about how that worked, some of which I've already said. It was a UK startup that was used that's also being used in Germany, and the results are looking really positive. Fewer calls needed by the clinical teams because they're not phoning people who are recovering fine, they're focusing on any deterioration, and that translated, particularly at the acute hospital site, to quite a time saving for their doctors. It equated to a full-time respiratory consultant every week. And we're now currently working with a number of other sites to get them live. A number have gone live already, and we're aiming for 50 by Christmas. And in a nice touch, the doctor who approached us was recognised with an MBE in the Queen's Birthday Honours a couple of weeks ago for his COVID response. So that experience led to our scale plans that have begun from September onwards, partnering with the 7 regions across England to scale digital innovations that enable remote monitoring to better support people from home. And we allowed regions quite a wide brief. They could, because what we wanted them to do was scale things that were already working well. We thought that was the greatest chance of having rapid and successful adoption. So they were able to choose from quite a wide range of remote monitoring. It could be people with long-term conditions, it could be people living in care homes, because we were very clear that supporting people at home, it applies even if your home is a care home. For 410,000 people, that's where they spend their days. And it could also include the acute monitoring of COVID. And each of those regions pitched to NHSX, and we gave them funding for implementation support, because we firmly believe that often it's not the technology, it's the change on the ground, the local bandwidth. People are busy, and that's what slows adoption down, rather than interest or desire to use things that will help. All bids were supported, and the scheme began in September. Quite intensive work over 7 months to reach over 100,000 people by the end of the project. We have written on this, there's some blogs out to tell you a bit more. And one of the other things we've done is worked on a procurement framework to make it easier to have local selection be quick. So we've run a process that's taken 5 months, and it means that for the NHS, they can do that within about 4 weeks. So we're trying as well to build the market for remote monitoring and make it swifter. And also it's an area where there are lots of mature solutions. So we're really keen that there's a nice ecosystem across the country, not a monopoly supplier. Next slide, please. And this fits into a bit of a jigsaw. I've talked about the regional scale plans. I've talked about simplifying access to solutions. Be worth saying we also got some COVID funding for licenses, which is reducing the risk even more to NHS organisations for this year. But we are also, a big area of focus is putting support mechanisms in for this group of adopters. So we've got a great online collaboration forum where lots of details posted, blueprints, really detailed data sharing agreements that people can use as a template, anything to just help speed up the replication. Eric Topol said at a conference, and he's one of my favourite authors, I think his book, The Patient Will See You Now, remains my favourite book on digital health. He said, share more and get smarter faster. And that's very much the mantra of the innovation collaboratives. We just held a launch event recently, bringing people together to share learning. And there are some other linked activities going on, which I won't dwell on, but they interlink rather well, including we're purchasing 11,000 SIM-enabled iPads for care homes across England to help join up between health and social care. We've done some work to look at really fundamentally different outpatient pathways in a number of playbooks. And in hypertension seems to us a great candidate for a very evidenced home solution. So we're doing some work to extend that to many more people over the months ahead, as well as getting an evaluation partner. And I won't go into the detail of this slide, but just the point I wanted to make is that where the evidence is strongest, not only do patients love the service, so Derek manages his warfarin entirely at home and doesn't have to go to hospital regularly as he did in the past. The evidence is that they stay in the therapeutic range for longer, so he's reducing his risk of a stroke by home monitoring. 70% of the patients who join the service improve their time in range by 20%. And this is exactly the type of thing that this fund is being used for. It was happening in one hospital in Durham, and it's being extended to all hospitals across the North East of England over 6 months. And I won't talk about this, but it's another example that covers learning disabilities and so on. Just to say we're very excited about the work, and we were really impressed by the coverage of the regional bids. And these are the topics that they're covering. We were interested that even with such an open brief, every single region is doing something with its care homes, which is fantastic. And the next slide just shows some of the kind of outcomes that we're hoping for. So in the Southwest, a 50% increase in the annual health checks done by people with learning disabilities through connecting them online. The Northwest has got a very well-established telehealth programme, and they have added to it significantly. Lots of work on people who are more vulnerable, and really pleasing to see that some areas that put in remote monitoring, saying 3 care homes during it to 60 to 80% of the care homes within a geography. So really quite rapid scale. And time won't allow me to say too much about that. I mentioned the innovation collaboratives. These are the types of things that service is doing. And we've had support. We've had specific commission to the Academic Health Science Network, who kind of lead on adoption and spread across England, to provide capacity to build a really lively programme to help support people to best effect. That's all I was going to say. The website for NHSX is there. AHSNs are also really important. I wasn't sure if that was going to already be covered by Linda's talk, but another good website to look at is the AHSN network. So that's www.ahsnnetwork.co.uk, I think, where because there are 15 AHSNs covering the population of England, and they have a remit for supporting innovators, particularly within their geography. But that could include, if you're working with a trust in Birmingham, let's say, then the West Midlands AHSN would be really keen to hear more about what you're doing and may be able to offer some practical support that works much better because they've got the local relationships than anything we'd be able to do from a regional perspective. And a little more on the subjects that I've talked about, if you're interested, is a range of blogs on. And I'll stop there because I was keen to leave a good amount of time for questions, but hopefully that tells you a little bit about how our approach to scale is as much focused on supporting the NHS as supporting companies directly, because we think that's a way of reaching many more citizens and staff quickly, and also providing support in building a market for digital health innovators.
Fantastic, Tara. Thank you for that. I think really interesting and very inspiring to see what's being done. We've got a couple minutes for questions. So if you'd like to either type your question into the chat or use the raise your hand function. So we have a question already from Raina. Is there a collaboration platform for the home monitoring structure?
Yes. So there is a fair bit of info on the main NHSX website. We've just been starting a campaign with case studies, all of them from the citizen who's benefiting. There is also a microsite for the Innovation Collaborative, but that has been kept specifically for staff in the NHS and in social care. It was agreed with the members of that group that they wanted quite a safe space to talk about issues through, so we're respecting that at the moment. But we are actually going to run a poll, because most of our microsites would be completely open to everybody, to see if people want to do that in the longer term, or if it would be a place that we could be a bit more relaxed about who joins.
Fantastic. Another question from Glenn. How much attention are rehab services getting, for example, physiotherapy and falls prevention?
Yeah, so that's interesting. It comes up quite a bit, and in particular, there's a tool called Safe Steps that's been used very successfully during COVID in care homes, which is all about falls prevention, and it has a really interesting, statistically significant impact on the number of falls, and that's one of the tools that people are choosing to scale as part of this work. So obviously preventing somebody going to hospital is a brilliant thing if you're able to do that. And in fact, some of the benefit cases that people have written have been exactly about that, reducing the emergency attendances from care homes due to falls. Physiotherapy a bit less in this particular scheme, but we are seeing there's been a national COVID recovery online programme that's been launched. So there's certainly a number of sites who are doing more and video-based physiotherapy, companies like PhysiTrack being used quite a bit. But this specifically was a call on remote monitoring for long-term conditions or care homes or acute COVID, because what we feel is that being quite specific, we're more likely to get things done than if we kind of boil the ocean and try and sort out all problems all at once.
Fantastic, thank you. A follow-up question from Reina. Is there a mandated API structure for integrating with the platforms?
So that's a really good question. We've asked questions about interoperability of all the companies who've joined the procurement framework. I think it's something that will. So we at NHSX, one of our priorities is standards, and we've recently recruited a fantastic director of interop and standards who's working through where the need is greatest and what best to link with what. Interestingly, in COVID, platforms were completely standalone, and clinicians preferred that because it was more of a dashboarding thing than actually getting into the clinical record. But over the longer term, we'll want them to all link together. probably using an international standard such as FHIR. That work is happening at the moment, and during the course of this year we're doing some small discoveries to look at how we could help that question best nationally.
Fantastic. And one more follow-up from Glenn. Does a digital health supplier need to be a resident in the UK to participate in programs?
No, they don't. No, all our calls so far have been open internationally. AHSNs have a specific responsibility for innovators who are based in their geography, but there are a number of them also do work with international companies. And some of that might be paid for and some of it might be free. And if you have a link, as I was saying with the Birmingham example, where you're already working with a trust, that would be fine. And it'd be well worth talking to the most relevant AHSN, because they have a commercial team and they receive some money from the Office for Life Sciences for their innovator support function, which can be diagnostic. Some of them run really intensive accelerators over the course of a year. Certainly the one I was involved in London was open to applicants from any country. So yeah, that shouldn't necessarily be a barrier. Sometimes there's an issue about where the data is held, but you can work that one out.
Great. A question from Mark. Complicated NHS tenders can be a real barrier to access, especially for small companies with limited resources. Any tips on how to navigate those tenders for smaller companies?
Yes. So one of the things that we've done over the past year is in recognition of this, and I think the other thing that comes up is not so much that the process is difficult, but that some of the hurdles that have been put in unintentionally rule out smaller companies. An example would be having 3 years of accounts, which might not always be relevant. So we've done some work with the procurement team at NHS England, and the major framework that's used is the HSFF framework, and created a new category. It's called the Innovation Greenhouse Lot 0, and it has slightly different requirements to enter and is considerably simpler. Another thing that has been, that continues to be an important requirement is assessment criteria for digital technology, and we've done a lot of work on that in this country on evidence for effectiveness, but we've recently reissued our standards in a very doesn't make it easier, bar is not lowered, but it is rather than a 32-page document, there's essentially 4 categories of questions that people need to answer, and that links with all our procurement stuff. So once you've done that once, it will simplify the process going forward. But I'd have a look at the HSFF Lot 0 because that is intentionally designed for companies at an earlier stage.
Fantastic. I think we have time for one more question. I did see a raised hand from Stefan Jernberg. Stefan, do you still have a question? In case yes, do you want to go ahead and unmute your mic? Otherwise, let's see. Okay, fantastic. Covered everything. Tara, thank you very much for sharing your insight.
Edward, could I just ask, is there anything similar happening in Sweden on the remote monitoring specifically?
I am by no means the expert on that because my focus is very UK based. Johan or Gustav, do you want to chime in in case you have any knowledge?
It's Gustav here. Hi, Tara.
Hello.
I think things are happening in Sweden in this context. We are up in the north of Sweden. We have a center of excellence actually around remote care in a rural setting. So very happy to update you on that afterwards separately.
Great. Yeah, that'd be terrific. It's just always interesting to have a bit of a two-way dialogue about what's
absolutely.
going on.
We'll connect with you after this call.
Great, and I know that later on you've got Juliet presenting, and funnily enough, when I came to NHSX, it was to replace Juliet, so we know each other really well. Great, well, thanks so much for having me.
Thank you, Tara. Fantastic. So,
thanks for
with that said, I believe we will move on to Tony Young. So Tony is the National Clinical Lead for Innovation at NHS England. As Noel mentioned, Tony is really a force to be reckoned with. Tony, do we have you on the call?
Yes, good morning.
Perfect. I'm going to stop sharing my screen because, Tony, I know that you'd like to share your screen and potentially have some images to show us.
Yeah, we'll work that out. Do I request control from you? Or how do we do that? Oh, look, open, share. How do I share my screen with you?
Let us see.
I can wing it. You don't have to have the pictures.
If you look at the top right-hand corner, Tony, next to the leave button, there should be a sharing button. It is on my screen, at least.
At the top right. I've got more actions. Let's have a look. Do you know I can wing it? Why don't you just put me in the center and we'll go for it. It was always going to be an issue with Teams. Can you make me in the center and I'll just talk to people? I'm quite happy to do that. Ooh.
Yep. I believe I've done that for my screen. Hopefully it shows the same for everyone else.
I still see me at the bottom and see you in the center, but I'm assuming other people can see me in the center. And I don't know what other people were happening. I was having there was a real crackle noise. I wasn't sure if someone was revving up their motorcycle in the background for the last one. So hopefully it's a bit quieter in Southend-on-Sea, where I'm speaking to you from today. So I'm just going to assume you can see me in the center of your screen now. Although I can, that's not what I'm looking at on my screen. So I really hope you can hear me, because the poor person whose face is now up front and central for me is responding every time I laugh, which I quite like because it kind of makes it a real thing. Everyone's going, who is it? You know, I'm not going to tell. We'll leave that a mystery. But one of you's in the center of my screen. Right. So thank you, first of all, to the ambassador and to Business Sweden for asking me to join you today. And I was going to show you a couple of beautiful photos, actually. But do you know what? I'm going to share them with the Business Sweden team, and you can see them because they're photos I'm super proud of. And we're going to be the base of my talk, but they'll still be the base of my talk, except you're going to have to wait with anticipation to see them. So that'll make you'll open up the follow-up email from Business Sweden now to go, what was he talking about? How have they broken ground in this space? So colleagues have asked me to cover a whole range of things and looking at the NHS, and we've just got 20 minutes. So first of all, a quick introduction. I am still a clinician on the front line of the NHS. I'm a consultant surgeon based in Southend. I would show you the view out of my window, but it's not of the seafront. I could step out of my front door and you can see the seafront from those are the benefits of home working, aren't they? But I'm also an associate medical director for one of the largest hospital groups, the Mid and South Essex Group. We look after 1.2 million people in the UK. And I'm responsible for innovation and transformation in our systems and processes there, particularly the digitization of outpatients. I'm also the chair and director of medical innovation at Anglia Ruskin University, where I lead a number of things at the medical school there. But I'm also the national clinical lead for innovation at NHS England and improvement. And so across local clinician provider, still operating on people and doing on calls, regional kind of medical director roles, important for transformation, and then a national role in policy oversight, and run a range of national programs, and kind of one of the senior clinical leaders and advisors in the system on healthcare innovation. So I get to see a lot of things. But my privilege today is I'm the warm-up act for Juliet Bauer. What a privilege. I've known Juliet. She was my colleague at NHS England, and you're in for a treat with her later. I tell you, she's really going to get the thing going. So look, we are a friendly and open place. And I saw the question earlier about it can be difficult to apply for NHS, procedures. And I thought, oh, have you tried applying for an EU one? I think the NHS can be quite strict. No, I mean, no offence to EU colleagues. I just had to go through one myself recently, and I went, gosh, I didn't realise there must be more to life. So the NHS, what do we've got lots of support and different structures and systems in place. I'm sorry, it's super complex. If I was the boss of it all, I'd try and simplify it. But, you know, if I was the boss of it all, I'd probably realise it's complex for a real reason, because it's such a big organization. It's the world's largest unified healthcare provider. We've heard that already. And although it's one name, actually there are many thousands of components that make that up. So I'm going to try and simplify that for you a little bit. We've heard from other colleagues and speakers already. So from, I mean, my understanding of the audience we have today, it's around digital health companies and medical technology companies, particularly, who are looking in this space, and they want to work with the world's largest healthcare provider. I get that. I had recently, the one of the global vice presidents of Bose, you know, the speaker manufacturers, really high-end ones, they're getting into hearing aids. And they flew over to see me. This was pre-COVID, clearly. I was happy to see them in my diary. And they said, I said, well, why have you come to see me? And they said, well, do you know, you're the largest purchaser of hearing aids on the planet. And I said, do you know, I did not know that. They said, yeah, so we're about to go with over-the-counter hearing aids, and we want to get some feedback, opinions. How might we access this market? But also, what insights and views have you got in this space? So actually, sometimes it's about getting those opinions, those thoughts. What direction are you moving in? What trends and observations are you seeing that help with businesses? And we do a lot of that in my team at NHS England. So I sit within a team called IRLS, which stands for Innovation, Research and Life Sciences. So we're the team that help with policy and delivery. And we are twinned, we're almost conjoined twinned with an organisation known as the Accelerated Access Collaborative. And we can provide links and details to that. And that is the engine that government have set up for trying to make the latest, greatest things happen at scale across our system. And if you have a look at their website, it's chaired by Lord Darzi. We have our Secretary of State, our Health Minister on there, the Chief Executive of the National Health Service. So they're stepping forward and saying this is really important for our nation, making sure the latest, greatest things are available for us. And we're going to bring together the system and the system leaders within this to try and make this happen for you. So IRLS team at NHS England, who kind of commission of the innovation services that go on in the NHS, and the Accelerated Access Collaborative that work in partnership across bits of government and industry to make sure we're getting things taken up at a national level. And we have nationally commissioned some things. Some of you may be familiar with HeartFlow, which came out of Stanford University, machine learning, artificial intelligence algorithms around predicting whether a coronary stent would actually benefit you. Or if you'd be better off with medical treatment, and we've commissioned that and rolled that out nationally. But there are a number of other examples I could have given you. But you've got to be quite advanced, have the evidence to support the uptake of that kind of innovation. So we have an architecture for innovation and adoption to help you. And we've already heard Tara Donnelly mention this earlier, that academic health science networks really are the front door for innovation in the National Health Service. We fund 15 of them right across our country, and those should be the doors you are banging on. And if you Google, or would you have a search engine of your choice, I should say, if you look at AHSNs and AHSN network, you'll find all 15 of them there, and you can go and approach them. Not everyone will want to have a discussion because maybe it's not a particular specialist area for them, but you'll always find one. And we fund those centrally from NHS England. And there are a number of programs that come down from the IRLS team in addition to that. So we have our SBRI Healthcare, the Small Business Research Initiative. So we put about £5 million a year in that, but I think that's going to change. We had the spending review for our government yesterday. I think we're going to see more support coming forward for such initiatives. And that's we run themes. We've just run a call recently around urgent and emergency care. And you can come from anywhere across the world. You don't have to be a British registered company to do that. And we will give you funding at different phases, up to £100,000, up to £1 million for the second stage as we go forward, to help you try and get your business idea tested, trialed and taken up in the National Health Service. We have a National Innovation Accelerator. So for those ideas that just have proven themselves, but need a place that will help support them to embed and grow across the system, have a look at the NIA, National Innovation Accelerator, really great opportunity there. And then the program I run at NHS England called the Clinical Entrepreneur Program. And that's really great. That's from, those startup enthusiasts And we've really uncovered something here. So, you know, in the National Health Service, we'd always supported, if you wanted to be a clinician or an academic or a medical leader or a researcher, you got our blessing and support. But if you wanted to be an entrepreneur and work in the NHS, quite frankly, we did the opposite of support you 5 years ago. But when you look at the United States, they embrace their entrepreneurs. They go, you know, you are our heroes of the future. You're going to help us save healthcare. And there's a lesson for us to learn in that, because if we are not working with the startup world, with those earlier stage to mid-stage companies, where the latest, greatest innovations are being born, company, you know, a startup is essentially an experimental methodology to allow you to see if you've got an idea, A, that works, and B, can you scale it? And if we're not embracing that in the National Health Service, we're not going to make the latest, greatest things available to our patients. So I persuaded my medical director, Sir Bruce Keogh, and Simon Stevens, my chief exec, about 5 years ago, we should support this. So we launched our entrepreneur program. We give commercial coaches and mentors, whole load of educational days, connections to customers and funding in the system, test beds for trialing those innovations and taking them forward, whole load of industry days. And here we are 4 years down the line, and this program that got very little financial support from the centre, but lots of blessing and encouragement. We've started up over 226 life science companies. They have raised over £250 million between them, mostly private sector funds. They've created over 1,500 jobs. 140 clinicians who quit the NHS have come back to work in it at least part-time. But amazingly, the entrepreneur program is now responsible for 4% of the UK life science industry. And we've done that from scratch in 4 years. So I would say to you, what better place in the planet to come and work with a country that is prepared to invest and support startups on a scale and a successful scale that has not been seen before anywhere. Now, the pictures I was going to show you were two amazing things, and I'll send them. Two of our young entrepreneurs. One is, it's one of my favorite pictures. He said, oh, I'm sorry. So it's a Formula One racing car from Red Bull in the background, and in the foreground is a prototype ventilator. So when the COVID pandemic hit, one of our entrepreneurs had a low-cost portable ventilator that he developed. He got to pitch in front of the Cabinet Office and got given the funding, was embedded in Formula One, and in about 4 weeks they spent about £10 million on making sure if we needed the ventilators, we had 5,000 ready to go off the production line that weekend. Well, it was just before the weekend that this happened that the government realised the numbers were changing. We weren't going to reach, thank goodness we weren't going to reach that level, and the programme was paused. But never before have I ever seen a medical device lab with a Formula One racing car in the background. It's just incredible. And the next picture I was going to show you, which I will share with colleagues, was the NHS Robo Squadron. And so two of our young startups were really keen on drones. And about 3-4 weeks ago, if you Google NHS and drones, you will see it. Came up, we got £1.5 million of funding from the UK Space Agency. My hospital group have worked in partnership to help us look at using autonomous logistic drone flights between different hospitals in the NHS to try and deliver essential supplies like PPE, to take testing swab kits from site to site so we could get those test results earlier moving forward. And the ambition is to set up a national air grid for autonomous drone transportation across the NHS. Now, isn't that a country you'd want to come and work with? I don't know anyone doing anything like that. So, and we've got a beautiful picture on the helipad at Broomfield Hospital with our two young entrepreneurs there and the Rainbow Drone Squadron from the NHS. Which I just love. So there we are. Anyway, you'll see those pictures. So look, we are, I think the NHS, it's the world's largest unified healthcare system. And sometimes it can seem like a super tanker that's set in one direction and you're never going to turn it around. Well, do you know, with people like me on board, with people like Tara on board, with people like Noel, who are one of our senior leaders that you've heard from earlier, backing us and saying, more of the same isn't going to crack it for us in healthcare. We need to do something differently. We need to work in partnership with industry, which is why I'm so delighted. I mean, you're going to be hearing from Juliet next, and it won't be a story of roses and a great loving. There are still issues and challenges, but are we determined and committed and driven to try and make this happen, to hold on to those gains we've made in COVID, to continue those relationships and further develop them? 100% we are. Now, I appreciate I'm nearly at time, so I'll leave a little bit of time for questions, if that's okay. How was that?
Yeah.
I hope I covered the things you kind of asked. And I'm sorry about, I can't put a lovely picture in the background like you did. My technical skills failed me.
Not a problem. No, thank you. Really interesting, and we'll definitely share those slides of the examples you mentioned, because I think those sound like really very interesting, very cool initiatives. We do have 2 questions that have come in already. So from Craig, how can we access the NIA and other resources?
Okay, absolutely. So if you just have a look at that, you'll find it. You can link to it through the NHS England webpage, but actually it's run by UCL Partners, who are one of our academic health science networks. So if you just Google NHS and National Innovation Accelerator, you will see it. They've got a website, a range of resources and support. This year's application, the process closed a couple of months ago, I think. So we're just selecting the innovations that are going to be taken forward over the next year, but keep your eyes, you can register an interest with them on that site. Look at the examples of companies who've been on that before. Maybe reach out to them and see what their experience was, and what things they found of value, what they learned, those kinds of things. Because actually, one of the things I've found that works most is companies who've got experience within our healthcare system, who've managed to do something, talking to others and exchanging what worked, what hasn't worked. And that's the networking between companies, really valuable thing.
Thank you. And then a question from Reina. What is the process to build evidence at the NHS? You may have mentioned this, and also I was wondering if we can put together a list of the agencies mentioned, and we'll definitely look at doing that and sharing that as well. But in terms of process of building evidence.
So it's like with anything. So sometimes people think.
Oh, sorry, I think Tony, you muted, got muted accidentally.
I didn't touch
there
that.
We go.
That was probably, there was probably some crackling happening again in the background. Who knows? So I can see Juliet smile every time she's hoping for some interference on the line. So a research, do you know, you do need it, and it is important, but people think that first of all, patents are really important in intellectual property, and then I've got to have this randomized double-blind controlled trial to get through NICE and evaluation. Sure, you do, and you do need certain amount of evidence, but actually there are some things that you don't need evidence for, that are so straightforward, or not the same high level of evidence that you might otherwise require. There's a lot. It's quite a big question. Perhaps the easiest thing to do is to share the resources, and I'm happy to provide a link to that, with the NICE, the National Institute for Care and Health Excellence. Has a whole range of resources linked to on their website about building evidence. The Accelerated Access Collaborative too have that, starting from very early stage things around clinical evaluations and retrospective reports, then moving further forward with that. It's not easy and it's not straightforward for anything, and it requires finding your clinical and your academic champions. Our academic health science networks are very good at that, finding that person who is as committed as you are to making this particular area work and take it forward. So there is stages and processes, and those have all nicely been documented by NICE. But it's not easy and it's not straightforward. But there are some things. So I got involved with a device called SpaceOR, which is a gel you inject in the perineum to separate the prostate off the rectum, so you get the prostate out of a radiotherapy field. And it was criticised when I was sitting on this committee reviewing this, saying, "Oh, there's not enough clinical evidence for this. We can't push it through." And I just went, "What? we don't need randomized double-blind controlled trials for this. I said, I'm taking a healthy organ, which is the rectum, out of a radiotherapy field. Why would I expose that to radiotherapy when I don't need to? It's like asking me if I want to do a randomized controlled trial on parachutes. I tell you what, we're standing at the entrance to the plane. I'll have the parachute, you be in the randomized arm, and then tell me you want, some things just make sense. And so level of evidence has changed on those things. But we need to embrace technology. We need to a safe and appropriate and measured manner. I get all that. But, and we need to accelerate that too. So I'm super keen about doing it. I'm super keen at looking at the barriers, the hurdles that have been put in our way, and how can we get around those and through that in this thing. And the NHS is open. We really, really want to work with you and help make this happen. Is it going to be easy and straightforward and done tomorrow? No. Am I passionate and driven and committed and want to make this happen tomorrow? Yeah, sure.
Fantastic. Thank you, Tony. I think what I hear there is also that finding those champions in the system can be really important. So fantastic. I think we'll have to pause there to get to our next speaker. Again, our sincere thanks, Tony, for sharing your always very deep insight. Very much appreciated. And we'll, as I said, make sure to share those slides that you had with the audience.
Thank you.
So with that, I will share my screen again. We are very lucky to have Juliet Bauer, Managing Director from Livy and Cree, joining us. Juliet, are you on the line?
Good morning, I am. Can you hear me okay?
Yes. Can someone confirm
my presentation? So
I do. Can someone confirm that they see the presentation up and running again?
Can see it perfectly.
Fantastic. Okay. Fantastic. I will hand over the word to you, Juliet, and please take it away.
Okay. Thank you. I'm not sure about following Tony with all his expert performance, but hopefully I will tell you some useful stuff this morning about Livy's journey within the UK. Probably for this audience, you've heard of Cree, so I don't need to do a full introduction to Cree, but I wanted to talk a little bit more this morning about our journey with the NHS, about coming here, what we've achieved, how we've achieved that, some of the challenges, and maybe some tips. I thought I might start with a test on some of the acronyms that Tony used, as some of them I had indeed learnt for the first time. But then I thought, actually, that's going to be quite dull, so I won't do that. I'll go straight in and talk about Livy. We are, of course, part of Cree. I'm getting better at pronouncing it, but I'm sure you'll all agree I'm still pretty bad. And are Europe's largest digital healthcare provider. We very much focus on delivering patient-first digital care, and at the heart of what we do is something that, to use Tony's words, just makes sense, which is give people good access to primary care in particular. We now do a whole range of other things, and I'll talk a little bit more about that journey. We were founded in Stockholm in 2014 by Johannes, and he, as he proudly says, is a patient. And I will repeat that endlessly because it's so core to our values and so core to what we do. This is very much on thinking about how do patients want to access healthcare? How can we, in a sense, keep it simple for patients, but live up to the promise that healthcare can deliver? Now, since the pandemic, we are live in over 35 markets, and that's with a range between provision of healthcare and then software and tools that we also provide in various markets. I'll talk a little bit more about that in a minute. And I think we're now nearing 3 million consultations using our 2,000 clinicians across those countries, in particular Sweden, Norway, Germany, France, and the UK. So on to the next slide. So what we do, we're more than an app, but again, to reiterate, we are trying to keep this simple for the patient, and in the patient's mind, the main interaction they will have with us is using the app. We provide patient-initiated video consultations. Feel free to download the app and have a look if you haven't had a look at it already, across the NHS in this country. That includes doctors, nurses, we also have pharmacists on our platform and psychologists coming soon, and then a range of other tools that sit around it. But more than that, this is about redesigning and helping the healthcare systems across different countries to think very much about digital services across whole areas. And in the UK, that now increasingly means wider than just primary care. So also thinking about how we interact with urgent care, how we can take pressure off A&Es, how we can integrate with other NHS services that are out there. And of course, what we want is to make sure we provide people with the right care at the right place and in the right time. So, key to our success is efficiently matching our clinicians to the patients at the moment when they want it. And because of our scale, and I'll talk about that in a minute, we're able to do that very effectively to make sure, for example, as the pandemic progresses through the country in different areas at a different pace, we can put doctors where they're needed, when they're needed very quickly. We've been able to do that and we're able to scale up and down on demand as needed, such that within a week we can go to 10 times the size we were in some areas of the country, for example, Tyneside, using doctors from other areas if that's what's needed. We also, of course, have various tools to make sure that the right patients are getting the right care and that demand on the system is not too great. Behind the scenes then, we also, of course, have a range of clinician support tools. And recently, we've just bought a UK organisation called MJOG, which also provides software and patient engagement and messaging to 75% of the practices in the UK. So on to the next slide. So just to talk through our journey in case it's helpful, and there may be questions on this, of course, so we'll take those at the end. In under 18 months, we feel we've become the go-to digital provider in the NHS. We absolutely believe in what was said earlier by Tara. This is not about having. We absolutely want there to be a vibrant marketplace of different digital tools within the NHS. That's what's best for the system.
Uninteresting. It's quite many about just digital things.
Sorry. Should we do questions at the end? Is that
Yes.
Okay.
Yeah.
Sorry.
Okay, no problem. So we now have contracts covering a population of around 5 million NHS patients, and as you can see, those are dotted around different parts of the country. I'll talk in a minute about kind of what that takes and how we've achieved that, but suffice to say, those are all local contracts. So those haven't come from just doing one thing nationally. Those have come through selling to the NHS at a local area. And we've grown from, I think when I joined, we were around 20, but I think now we're 100 staff in the UK and we have over 200 doctors. So, that's significant growth, of course, and that's enabled us to support the NHS in various ways during the pandemic and in normal times. We're working now in all of the 7 regions, NHS regions, and of course, because we have MJOG live as well, that's in 70% of the practices. And we've seen significant growth, and this numbers the provision that we provide, so 300% more consultations with our clinicians since last year, and then a huge growth as well in the use of our software tools by clinicians and GPs within surgeries. And as I just said, acquired MJOG to make sure we have the tools that are needed. I've always said, I think when I worked in the NHS as well, as Tara said before, that a lot of the challenge with the NHS is how do you keep it simple for patients? How do you have a really simple, compelling consumer offering that people can understand, where they know where to go and they know what to do? Most people absolutely want to help the healthcare system and don't want to use the service if they don't need it, but we need to often make that easier for them. And a key part of that, of course, is consumer messaging. And that's why we've bought one of the biggest consumer messaging tools out there, MJOG, to make sure we can help make that simple for patients and enable clinicians to message their patients. So some kind of strategic shift there in order to achieve what we need to achieve. But all of this very much sitting within partnering with the NHS. We have not approached this market with the idea that we disrupt everything. We've absolutely approached it with the idea that we can partner with an existing system that does many, many things very well and is incredibly well trusted, of course, by patients and the public within the UK, that we can partner with that system to support it rather than disrupt it. On to the next slide. So what are the ingredients of the UK success? And maybe a little simplistic, but I think worth reminding us. It is offering, of course, something that's better for patients, that's better for doctors, and then something that's overall better for the system. And of course, we talked earlier about acquiring evidence on that to make sure that that is true and it is better for all of these three groups. And that's very much how we approached it. In the first area of the UK that we came, initially, we did a very thorough pilot with one part of the UK before rolling out everywhere else. Even though there were opportunities to roll out faster, we were absolutely convinced that what we needed was to get the local evidence that the service worked for all these three stakeholders in order to then go to the rest of the UK and present that evidence and say, and I think it's proven to be a good strategy because it means we do have, you know, a robust way of looking at how our tool can help. So, you know, we absolutely know that we can offer accessible care. That, I mean, looking at the thousands of patient experience feedback that we get every week, not a moment goes by where someone isn't delighted that they can get a doctor's appointment within often less than half an hour, sometimes much quicker than that. We know, you know, that people are delighted by the fact that they don't have to leave their existing GP surgery, that they can work with us in order to get the benefits of what we offer, but they can stay with perhaps their local GP surgery that they may very much trust and want to stay with. Also, of course, we get incredible feedback from our clinicians, so our retention rate of clinicians is very good, and our recommendation scores, NPS scores from our clinicians are also very, very good. And they love that it's flexible, and of course, during the pandemic, that's been absolutely key. And most of our doctors say that because of the way we work, they're very much working more hours than they normally would work. And then in terms of the system, we know that we absolutely are supporting, especially during, you know, the COVID pandemics, supporting local practices at key pressure points as demand ebbs and flows throughout each year, and that has been hugely valued by the system. And that we can be incredibly cost effective because we actually can provide a lot of appointments in any given hour across the country. So lots of different things that we're doing. And if you move on to the next slide, I'm afraid I did add the heart only just before this presentation. I think this magic triangle, if you like, when I say national sponsorship and endorsement, what I really mean by that is looking at the long-term plan and all the other things that are published out of NHSX and the various other sources that the others have talked about this morning, and making sure that the thing you offer really is something that is a priority to the system. If it's not mentioned somewhere within the long-term plan that there's a kind of problem to solve that you're solving, then it might be more challenging for you to get your idea solved. And that, of course, is not 100% true. I'm sure drones with rainbows on were not mentioned in the long-term plan, but it may well be true that you need to make sure you've got this kind of national cover, or that nationally there is something that relates to what you do within one of those key strategy documents in order to get the kind of fast take-up that you could achieve. Also, of course, key, based on the fact that, you know, almost all, that all our contracts are local, is of that's where, you know, it's challenging, and that's where Tara was obviously talking about innovation accelerators and all the different tools you can use to find out where's the areas with the problem, who are the individuals that I can talk to. And then, of course, the third part of the triangle is, you know, frankly, a lot of grit. This is not easy. No one said it was easy, but it's certainly a lot easier to work with the NHS than it has been before. And that's, you know, thanks to a lot of the things that the others have talked about happening in the last 12 months. But that said, you're still going to need some grit. You're still going to have to go out there. You still may have long sales cycles, and you have to, you know, be aware of that before you come in. But it is certainly true that those cycles may be a lot shorter than they were before, and that there may be, you know, a ton more frameworks and things that you can actually make that much easier than before than there were 12 months ago. So that's good. And then on to the last few slides. Kind of where do we go next? I mean, across all of our countries, there's a whole host of different things that CRE are doing. We do some physical healthcare now as well. We're absolutely looking at different monitoring integrations. So some of the things that Tara talked about earlier are absolutely part of what we're doing in different markets. Mental health, of course, we're all fully aware of some of the challenges that are happening around mental health related to the pandemic, of course, and there's a whole set of tools. There's psychologists themselves, of course, and there's also a whole set of other tools that we could do to support with that. We've launched our first urgent care offerings to make sure that we can enable people in different care settings to access digital consultations. And then we're kind of moving beyond the kind of solutions to say, how can we co-design with the system across a larger geography, not a national geography, but a larger geography, something that kind of works across the different settings and seamlessly ties it together, but still delivers on the core promise of access to healthcare. So I think hopefully that gives you a slightly whistle-stop tour. I hope I wasn't too long on that, but hopefully not. And please feel free to ask me any questions.
Fantastic. Thank you, Juliet. I think no, a really good overview, and I think from my perspective, always very interesting to follow Livy's journey in the UK and the news that seems to constantly be coming out about growth and the new partners that you're supporting. So we have time for a couple questions. To kick it off, one from Reina. Did Livy initially go through NHS, or did you go direct to market? And when did Livy decide to join a framework in the process of market entry?
Yeah, so initially we went direct, I believe, to the local market. I obviously wasn't at Livy at that time. So the first conversations were local, but we've always been quite abreast of what's happening in the national landscape for sure, and different frameworks as and when they come up. And as you know, there was a new, or you may know, there was a new DPS framework that came up quite quickly at the beginning of the pandemic, and us and a number of other competitors joined that framework just to make it easier for the local teams to know how to purchase these things. I think what the NHS probably doesn't want, and this is why these frameworks can be useful, is for every local organisation to have to kind of redefine how they purchase different digital tools. That would be a collective shame in terms of the amount of effort, and that is where these frameworks often can help. So we have joined frameworks as and when they come up, but a lot of the work is still local and engaging and building partnerships and relationships with local.
Fantastic. Can someone hear me? It seems like my computer might have frozen.
I can hear you.
Okay, perfect.
Anyone else can, but otherwise, conversation.
Good. Maybe I actually have a question, unless anyone from the audience would like to chime in. So a question from oh, there we go. There's a couple more. So a question from Glenn. Do you have a pay-per-use fee or an enterprise agreement with the NHS? Or do you see kind of a benefit in one versus the other?
Yeah, I mean, I think, generally we talk a lot across the system in all of our countries about what the best model is, and, hybrid models probably are the best. So some of the benefits that you'll get with kind of the capitated models of how you manage a population's health, some of that, provides a lot of benefit. And then also in terms of fee per action models and other models in primary care, that can drive uptake really quickly in terms of engaging digital primary care providers, which is obviously the space that we're in. So both is the answer, but in the UK, we're on a transaction model predominantly.
Fantastic. And then a question from Stefan. Would you say a local UK company is required or beneficial, or can you succeed as an international company?
I think you can succeed as an international company for sure. But, a lot of that comes down to grit. I will use some value terms rather than specifics, but humbleness, understanding the hugeness of the NHS, understanding. I think when I was the other side of the fence in the NHS, I think there was a lot of people who came to me with solutions who seemed to have no idea that there were another 150 solutions very similar to the one that they were pitching. So understanding the kind of scale of the market here and the number of things that are out there, but I don't think, or at least I haven't seen that there's people are in any way penalised because they're international, not local. I think what is key is to get that local evidence, if you possibly can, as soon as possible, because I think local evidence is seen as very compelling, if not essential, in this market.
Fantastic, and that actually covers the question that I was going to ask in terms of the evidence base that you see as necessary. So yeah, thank you for that. I think we have time for one final question. So I just saw one coming from Glenn. What political challenges do you meet being a private provider, and any tips on how to manage those?
I think, because we are very much working in the model that we are working, which is working with practices directly to support them to give the care to their populations, I think we have, had fewer challenges than some. So I think my advice there would be, think through very carefully the model and make sure that works to the broadest group in the population. And that's obviously, we spent a lot of time doing that, and I think that's really helped us.
Great, thank you. Again, I think very insightful and great to get a little more insight into the journey. So that concludes our speaker sessions. I'm going to hand off the word to my colleague Johan Ottosson, who's the healthcare lead for our UK practice here at Business Sweden. He's going to provide some summary and some conclusions and touch upon potential next steps here for everyone. So thank you, Johan.
Thank you, Edward. A really interesting session, and I want to first of all really thank everyone who took their time to both attend, but specifically also obviously our speakers. So I know all of them are incredibly busy with everything that's going on in their regular jobs. So really appreciate you all taking the time. So just listening to what we've been hearing today, I think. Sorry, no, okay. I would say there's, for me, really five takeaways from today's sessions. And I would say the first one is the sheer size of the system. So I think the DIT video pointed to some of that. I think some of Edward's slides as well. A lot of the work that Tara spoke of as well, I think really shows the possibilities in the NHS and the possibilities that system offers. And I think to my second point, also very much showing how digital solutions can support patients and how this has really exploded during COVID. So I think there's a lot of obviously initiatives going on to improve patient experience. Noel was talking about how COVID has really opened the door for digital transformation, moving the system much closer to connected health. And I think that was also evident in the three subsequent presentations. Tara speaking of assessment criteria for digital technology being simplified, Tony talking about initiatives such as the SBRI, NIA, and obviously the how Levy has really revolutionized how care is handled in this country. And so I think the high potential for digital solutions, but also the high potential for Swedish companies, that this is not a market that's completely closed off. So that Swedish companies be part of course, the opportunities and there are solutions available for our companies. So I think those are the first 2 points. It is a very large system and that digital has a very strong part. Third takeaway for me is really the complexity of the system. I think Tony said something in terms of one name and 1,000 units, and I think that a simile that I often hear is sort of, it looks like a whale, but it's really a shoal of fish, and I think that that's really key to understanding as to act as a supporting partner to this very complex organization that is the NHS. I think companies must really have a deep understanding of the system and how they can provide support thereof. And I think that here again, Livy is a really great example of that. And I think Juliet mentioned how they built their reach on local contracts as well, just illustrating that fragmentation, but how that's really important to understand. I think the fourth point I wanted to make, and this one is quite broad, is really about how important it is to understand where your solution as a company fits in. And I think this is one of the main challenges that we see also in our work with Swedish companies. And I think there's two levels to this. There's the macro level, and I think Juliet was talking about that, the sort of importance of identifying the sort of national commitment. Is this somewhere in the long-term plan? Where's the stated that this is a problem that the NHS wants to tackle, and also what value you can add as a company, and what local evidence can you produce from that. So that at the macro level, then at the micro level, really, and this links back to a bit of fragmentation and complexity, but really understand who do you need to target? Who is this solution that you're offering helping? Is really, really key. And also, I think both Tara and Tony were talking about that, but sort of need to ensure clinical support in this. And then just the final fifth point, which I think is really one of the most important ones, is the importance of working with the NHS as a sort of partner and not in competition. So this is both sort of from the company perspective, but also from what the system needs, and it's just really trying to work together and trying to ensure patient impact. So I think those are the 5 points that I take away from these discussions: the sort of largeness of the system, the potential digital solutions in the system, but also the complexity, the need to really identify where your solution fits in, and the importance of working together with the NHS on this. So with that, I wanted to link back to Noel's point from the beginning of the seminar. So really hoping that this has been beneficial to all of you listening, that you've really gotten a deeper understanding of how the NHS works, of the complicated beast, as I put it, I think, and also a bit better understanding of how to navigate the system and what kind of solution the NHS is looking for, at least where you might be able to find it. So I think that's it for me, and I think with that I'll hand back over to you, Edward.
Thank you, Johan. I think a very good sum up of what we've heard today, and I think from my perspective, exactly what you touched on: complexity, but also deeper insights into where the system is heading, and the types of kind of, in a sense, trends that Swedish companies can expect that the NHS will be working towards in the future. So again, I want to thank everyone for joining. I see a question from Craig about having the slides. That is my immediate next point. So we will be sending out an email as a follow-up with notes from this presentation, a link to the recording, and in case you would like to view this again, or in case you have colleagues who would like to view it. And we'll also be attaching the slides that you've seen today from our presenters. I'd like to again give our extreme thanks to the presenters that joined us today, and for them taking time out of their busy schedules. So again, thank you to Tara, Tony, and Juliet. And I'd also like to thank those that were working with us behind the scenes, so the Swedish Embassy, and also especially NHS, Ade and Jack, and DIT Sweden, Dario. I think without their support, this would have been a much harder endeavor. So thank you to everyone that's been involved. We really appreciate it, and we will be following up shortly with more information. And if in case of any questions, either following on from this presentation or once you've had a chance to have a deeper look into these slides and process all this information, please don't hesitate to reach out. We're always here to support. So with that, thank you again for joining us, and hopefully speak to any and all of you soon. Thank you.